Hello everyone, it is a great pleasure to welcome you to the Management Talk by the College of Management Mahidol University. My name is Prattana, Punnakitikashem, Deputy Dean for Academics and the Program Chair for Healthcare and Wellness Management Program. Today, our Management Talk is hosted by the Healthcare and Wellness Management Program. And today, it is very, very special, not only because it is our first session, but our guest speaker is very special. I'm sure many of you are his fan club in the YouTube channel. Let's welcome Dr. Tany Thaniyavarn. He is currently attending professor at the Harvard Medical School. He is also the lung transplant specialist, pulmonary and critical medicine from Brigham Hospital in the United States. And today we are going to talk about the future of healthcare management after the pandemic.
สวัสดีค่ะ Dr. Tany. And as many of you know that the Thailand has lifted the COVID-19 restriction since the 1st of October. And can you please share with us a bit at this moment, how do the hospital in the United States adjust themselves after the COVID-19 or after our pandemic?
Well, first of all, I would like to go back to when the pandemic started. Well, it hits the world like nothing ever hit the world before. And obviously, when we first know about COVID, many things go into actions. So number one is a new disease. So which means in the hospital, many people from different departments, they comes together to create a guideline, which means both all the knowledge around the world about COVID got reviewed by us every single day. So the team includes me, other students, other attending physicians from infectious disease, from pulmonary critical care like me, or immunologists. Everyone sits together and they review all the evidence about COVID. And then we create a guideline summarizing the evidence every day. So this is a huge task, but it can be accomplished by many people doing things together. Now, second thing, these days, like in Thailand, ATK or the rapid tests are very common, right? And you thought about it just like nothing. You can just swab your nose and then get tested, and whether it's positive or negative, something like that. But when you go back to when the pandemic started, there's no such thing. It's not even a PCR, right, about COVID. So people have to come together and try to make this PCR happen. In normal pace, typically it takes years to just develop one test. Now at my hospital, one day we were sitting and we said, we need to come up with a test that's usable and it has to be done in 1 week. And it was done in 1 week. In 1 week, we were able to test 500 samples in 1 day. So that's the power of human. You know, when we put our brains together, our effort together, something that takes years can be done in a matter of days. So that's also a huge deal and a huge work behind the scene that not a lot of people appreciate this. So those are some signs behind that we are having a team reviewing evidence every day. We try to improve our knowledge every day. And obviously when it first started, nobody knows how to treat COVID. So it all goes back to how we think about disease from the basic science world. So we always know in medical school that when the virus infects our body, in first thing it's gonna do is that it's gonna replicate itself, multiply itself, right? And then it create inflammation. Now, if your body is able to get rid of that virus, then it goes away. Now, if it does not get rid of the virus, then it will create more and more inflammatory reaction. And that's actually another hit that kills our body. So when we know about this, how would we apply the basic science knowledge to the new disease like COVID? So I remember seeing my first patient with COVID. We don't know what to do about it. We know maybe there's some medication that would work, but we don't know whether it's going to work or not. So I thought, well, the first phase is about the viral replications. So if I can give some antiviral at that time, it would help my patient tremendously, right? But the thing is that we don't have such luxury. So now we are dealing with the second phase. What that means is after about 5 to 7 days, the body cannot get rid of the virus. So they ramp up the inflammatory reaction in their body. And that, unfortunately, is double-edged sword. It's trying to kill the virus, yes, but also killing your body. So my thought was, if we can tame down the inflammatory reaction, that would limit the inflammatory reaction, and that will also limit the injury to your body. And that's what we did. We give some steroids or other immune suppressant medication. And I'm very lucky that I work in lung transplant. So we are very familiar with all kinds of immune suppression to begin with. And we tried that. It was a success. So patients got better. Then we start to have antiviral medication come out, antibodies, a lot of vaccines, and so on. So everything was developed at a very, very fast pace. So people may have thought about all these drug developments, which usually takes years. You put the patent on and you start thinking about it, try everything. Typically, drug development take years, including the vaccine that take years. Why can we do it in such a short period of time? It doesn't mean we cut corners. We actually do everything according to the standard of care. So we do all the testing of the vaccine the standard way we do with other vaccine. We do the same test to the vaccine the same we would do for other kind of vaccine. But it can be done in a very, very rapid fashion. So when we go back, the power of human being to try to achieve one thing, if we work together, it can be done. So most of these things, people may have thought that it might not be able to be done, but well, it is done now. Now, second thing is the major changes since the hospital capacity, right? You would remember the time when there's no bed in the hospital anymore. People have to be home, right? In United States, if you're not that sick, you stay at home. If you're very sick, then you bring the patients up to the hospital. You could remember in Thailand, initially everybody goes to the hospital, right? And I was probably among one of the first doctors who come out and say, Thailand should not be doing that. Because otherwise it will be exact same as the US, where the hospital got swarmed by all the patients, and then you don't have enough healthcare resources for those who really need it. So therefore, it come about the home isolation protocol in Thailand and other hospital, something like that. So that's kind of something that we would develop. Then moreover, next thing is, well, how about those who does not have COVID but requires hospital care, right? Because, well, people get sick. It's not all of them are COVID. Some of them, they probably have heart disease, they have stroke, they have diabetes, which is not controlled. They need to see their doctor, but the hospital are not available to accommodate them. Maybe their doctor got pulled towards the ICU or to see those COVID patients, right? So they don't have access to healthcare. Then here, how would we take care of these patients if the hospital does not have capacity? Therefore, the next big leap here is the computer and how we get through the patient, right? Telehealth, telemedicine. Very luckily that in the United States, we already have telemedicine to begin with. But it's not very, very popular, but we have the infrastructure, unlike Thailand, which I know that they don't have initial infrastructure, but it has to be done, Typically, if you don't have pandemic and you tell the hospital in Thailand, hey, we're going to start telehealth today. I don't think the hospital is going to give you any money to do so, right? They're going to say, you're crazy. We're not going to allow you to do that. It takes several steps in order to make it happen. But as you know, when the pandemic pushed people enough, that will happen. And in the United States, we have built in the telehealth with our electronic medical record. So in the United States, it's very, very common that most of the hospital, actually every hospital use electronic medical record, and we build in the video conference into that record. So we can actually see the patient, we can type in the notes in the same time. And this way, most people are able to get to us very easily. Obviously, it comes with an issue. What are the issues? Well, number one, what if you don't have access to smartphone? Or if you're older, if you're like 70 years old and the only thing you know about is the old phone, right? You don't even know how to use computer. You don't even know how to use iPad, let alone like Zoom or some other platform, right? So we have to set up a team to teach these people, go out to their house, teach them, or at least pair them with those who are younger to help them with that. And sometimes even some hospitals provide them an iPad to their house, or sometimes there is a center where the patient don't go there and use a certain computer in order to connect with the healthcare. So that is something that we would do. For instance, if I were to do that in Thailand, I know there's certain part of Thailand that has no way of communicating with other part of Thailand, especially if you live in a very, very far up country, right? You don't even know what iPad is. And even though you do have iPad, you might not have a signal. You might not have cellular signal. But I think this has become less of a problem that many people are able to access the internet anywhere. But obviously there's still needs for people to go down and help them. Those who are in central Bangkok does not have problems, right? They have all the resources they need, but those who are in the upcountry, they don't have enough opportunity to improve on their healthcare. So this is also another one that obviously in Thailand we need to develop. The same way as the United States, we also do the same thing. Now, not only that, when you have telehealth, you can talk to the patient, but you cannot examine them, right? Typically, you will be in the hospital office, like your glands here and there just to make sure that you're fine. But now we just look at you. We don't have the luxuries of examining you anymore. So how would we do the better job of doing that? There's a lot of medical device which is linked to the internet. What are those? Blood pressure machine, right? Oximeter, check your oxygen at home. It uploads into the computer. You check your sugar. If you're diabetic, you check your sugar, it can be uploaded to the computer. You can check your lung capacity, upload to the computer. This in America is still in the process of approval, but it's been done now. So this way we can have the patient have all the equipment at their house. They can test themselves and then upload the result to us so we see everything, all right? At least that will be something very good. I'm thinking maybe the next step is if they have electronic stethoscope, they can listen to themselves, record the sound, we can actually hear it. That's not something that is not doable. It's actually very possible. So those are some devices that can be hooked on to telehealth and we know exactly what they're doing. And that's very, very important. Now, once we are able to gather information, the next thing we want to do is prescribe the treatment. For instance, you need this medicine. You need to go there. You need to go to the emergency department, those kind of things. What can we do to prescribe you, let's say, Tylenol, Paxlovid, whatsoever that we want to do? So we have to have a network with all the pharmacists around the United States. And it's lucky because we do have infrastructure already to do that. Now in Thailand, I start to see there are a lot of people who developed an application on the phone so that you can seek opinion from your doctor, specialist, and then within the app, you can actually order or the doctor can prescribe you a medicine and they have their contract pharmacy that can send you a medicine to your house, right? So that's very important. Now, how about the payment, right? You order something, you need to pay something, right? And the platform in Thailand right now is online payment. But online payment does not get captured by your insurance. So because the insurance never built to do that before, they just built to bill from the hospital. You get your bill through the hospital system. It's not something like this. So it has to be built in as well. So now all the documentation we do online here in the United States are being captured by the insurance company. And obviously in United States, it's a lot more complicated because we have multiple states, right? Different states, they have different insurance, different policy, different coverage. And I don't even have a license to practice in other states. So how can I see a patient who is from different state when I don't have their medical license? So this is something as a system issue that we have to work it out. And there is an emergency grant that, okay, in the light of pandemic, doctors are fine to do the remote care for those who are out of state, and they are okay with that. So I think some of this logical thinking behind certain things needs to be correct. And it's correctable in the United States. I can show you that we have done that, and it's no problem. You know, rather than having to go through all the steps just to get approval, it's something that we can shortcuts. And when we see enough shortcuts, what that means to us is, well, does it really needs to be that complicated to go through all the steps? What that tells us is we rethink how we think about steps before pandemic happened, whether those steps are necessary or not. It turns out that many of them are not necessary. We can get rid of them, and then we reduce our workload and put the effort into doing something very useful to the system itself. So those are major change I see from the hospital standpoint, how we develop different things in a very timely fashion, how impossible thing in a normal circumstance would become really possible with everybody puts their heads together, cut through the hardship of going through steps like normal, but still keep the standard of care, standard of practice, standard of evaluating vaccine, the medicine, and everything. And also people, insurance, pharmacies, everybody is able to do telehealth. And that's very important. So I think these are very important. And what I think as a future, well, obviously those who are required and needed are computer science, obviously. But computer science alone is not enough anymore. They need to know what the industrial needs are. For instance, you need to know exactly what the hospital operates. If you don't know how a hospital operates, well, you cannot do anything. You can code the program, but if you don't know what we need, well, you're not being selected, right? You applied for a job, you might not get it unless you're able to prove that, hey, I know the system inside out of the hospital. I have been working in the hospital as an intern before. I gained some knowledge about it. I know what doctors actually want. And I was a patient, so I actually know how to get through all this telehealth. I know what the obstacles are. And therefore, if you're able to put this in your resume, I think that will be a good thing for you. So I think that will be summarizing everything. It seems a bit long, but I think it's useful for you to all know about it.
Thank you so much for answering the first question. So it seems that from your point of view, there are a few things that has been changed in a positive way. You mentioned about the power of human being, the power of teamwork, that, you know, when something difficult happened, if everyone they put an effort together, they can overcome the challenge. That's the first point, power of human being. That's very nice. And the second thing that you mentioned about the capacity management for facilities. And there are many things, especially the telehealth, telemedicine, that can be tremendous help and tremendous support to provide the care for many patients who can be stay at home, and at the same time you can free up the capacity of the hospital for other type of patient. And thank you for mentioning about the prescribing medicine or even the payment. And finally, you mentioned about the system that is something that worth to look into. Okay, that's the first thing. And the second thing that I would like to talk to you about is how about the healthcare professionals like physicians, nurses, that we heard lots of news that these group of medical profession, they work very hard, they have lots of workload, and many of them may want to resigned from the organization. What's your view on that, or how's the impact to the people, or how do the hospital manage this group of healthcare professionals?
I can definitely speak to that because I was one of them. When the first time that COVID hits, we all got recruited. And since we are certified in pulmonary critical care, which means the lung and all the ICU care or super urgent care, those kind of thing, I got recruited to look after COVID ICU. So it was very hectic and people got stressed about many things. So in that individual level, how I get by is by humor. We jokes around, we help each other out. So typically in the unit, in the ICU, what we usually have as a structure is you have one attending just like me. And then below the attending, there's a fellow, which means like a PhD in other non-medical world. And then beneath the fellow, there's residents, basically like a master degree. And below resident, there used to be a medical student. Now, when the COVID hits, there's no more medical student because we do not want to risk them exposed to this disease when they are not fully trained yet. So there's only me, the fellow, and the residents. And all the fellows are probably coming from different departments. So most of the time we would have our own department fellow who is specialized in lung and critical care. But when the COVID hits, I have all kinds of fellow, like cardiology fellow who is specialized in the heart, the nephrology fellow who knows everything about the kidney, those kind of people who helps us out. And we kind of share knowledge, like how can we get about today? And one thing as an individual level that panned out very, very good is how we prioritize problem, right? One patient may have 20 different kind of problems. And if you're new to the ICU, you see one patient with 20 problems, that's not only a thing. You have 30 patients. 20 patient, 20 problems each patient, you times it, and then you have 600 problems. How would you deal with that in several hours, right? You need to prioritize. So I would say, okay, in these 30 patients, who are the sickest? We need to take care of that person first. And in that patient, what are 3 things that will kill them? You deal with it 3 things first. The rest of them, let it be. Doesn't matter what. Let it be for now. Just deal with this very important thing. So as an individual level, we train everybody to be very, very efficient of how to prioritize things. And that's actually a very good thing. Now, most of people who go through the COVID ICU would know, like, what should we be prioritizing? We should not be just looking at, what does this blood work mean? Basically, it doesn't mean anything. It doesn't change the outcome of the patient. If you just take care of that, you miss the big picture. So that taught everybody in the ICU how to prioritize, how to look at the big picture. And obviously, sometimes there's certain patients we cannot save. We cannot save. Doesn't matter what we do. We try our best. We know this patient is going to expire soon at some point. Should we be putting all our effort for that patient? No. This is very, very heartbreaking for many, many people because not only for the patients, but for the doctor and also the family. When you have COVID in the ICU, nobody can come and visit you. You are there alone. And if you die alone. All we can do to help them out is we connect them via Zoom to see their loved one for the last time. And we go from there. This is very hard for everyone, and not to mention the doctor, the nurses, the technician who have to take care of that patient. We are so emotionally invested in that patient. So that also comes as a problem on top of the hours of work that we have to do. Now, how do we get away with all these things? How will we resolve this issue? Psychiatrists become our friend. Psychiatrists, psychotherapists, well, they are trained in stress management, right? So people like me, I'm trained in doing critical care stuff like that. Psychiatrists might not be as good as I do in terms of take care of the sick patient, or how to deal with the breathing machine, how to administer medicine, what medicine to give. They might not be as good as I do, but they're really, really helpful if you have stress. So there's some of a team as a stress management for all the COVID providers in the hospital. If we do have problems, we call them. Hey man, can you come talk to me? I don't think I'm feeling okay. They're very helpful. And more importantly, they come to the ICU and round with us. Why? We know that these patients are in distress, both emotionally and physically. If they're there, they might be able to help communicate to the family. And sometimes if things go south, if not things get better, they're helping us with what we call the end of life care. Not a lot of people would like to talk about this topic, but I think it's really, really important because, you will face with a situation one day, whether you're not like it or not. So having a professional who really knows how to deal with this situation, work alongside with us, is very useful. And that's the model that we have been doing in the ICU here at my hospital for some time. I'm not sure if that's something that Thailand can do, but it's something to think about, especially when you see people who are very, very sick in the ICU. If you have the psychiatrist who specialize in the ICU care and round with you, that's potentially can be very helpful. Now, what about those who are not being called in? For instance, if you're a dermatologist, if you are ear, nose, throat doctor, basically you are the last to be called for taking care of this COVID patient, because you probably are not accustomed to these kind of illness. You're probably more accustomed to your own specialties. So those people, they get bored, right? They have nothing to do, but sometimes they don't get paid because there's no patient who come see them. How would we help them? We kind of find different kind of jobs for them as well. For instance, the ear, nose, throat doctor, maybe they're good at doing the nose procedure. How about having them doing a nose swab, right? They can help with that. And dermatology, skin disease, there are a bunch of people who have COVID and then skin problems. Well, we have a telehealth and consult them like online. Hey, can you take a look at this rash of this patient for me? He's in the COVID ICU. Here's what's going on. Those kind of concept that we can involve them. And those who are not in these categories, like those who are peer researcher, they help us. Instead of just doing their own research in different things, let's say they're dealing with mice or cells or something, they change their focus towards COVID. And this way we have a lot of production in terms of new knowledge about COVID. So instead of like people scatter brain around and they do their own research, they focus on the same COVID. And we ask question, can you figure this out for us? And that way we learn a lot more. So this kind of involving everybody, make sure everybody has their own part, play their own roles, and therefore they have good self-esteem, right? They feel that they're important. And this way they reduce the amount of stress automatically, right? So that's how we get about. Now, there's no perfect way that we can get away without stress. So we have to support each other, and let alone there are news about vaccine. People would know that there are a lot of misinformation out there. Hey, the vaccine is not right. It's probably causing more heart disease, stroke. There's a conspiracy theories behind it. People are making vaccine to just gain benefit or those kind of things. I think that makes our life a lot harder, because not only we have to deal with this patient, and some patients who come, actually most of them who come to the ICU are not vaccinated. Like initially we see like a 9 out of 10 will be unvaccinated and lands in the ICU. And then it's hard because their family doesn't want to get vaccinated. And then they also end up in the ICU. Luckily right now, the vaccines are quite readily available, and the Omicron is not as severe as the other strains. So even if you're not vaccinated, maybe you're not going to be that sick, but who knows? Some people have a long COVID, which make things a lot worse. So those are stuff. And also our own people from medical staff, they caught COVID, right? So they caught COVID. What next? They cannot work. The same in Thailand, they have to have at least 2 to 3 teams on the same floor. If the first team got COVID, they're out. Then they have to call the second and third team in, the same way as in the United States. If you caught COVID, you're out until you're cleared. You come back again. In some country like Switzerland, you're not out. Even if you caught COVID, wear a mask, continue to work. I think it's a lot harder than United States, but that's them, So to me, that also play a lot of roles, because when you get COVID, many people have long COVID, so their productivity at work is not that great. And they mess up their memory, they mess up how they feel, depression, everything's set in. So it's very, very important for us to have all this psychiatry team to help them out. And not only that, financial, super important, right? We are underpaid for sure for the amount of work we have to do. We have to work, but there's no money coming in. We just get the exact same salary. So most of the hospital will try to negotiate a little bit of bonus for those who work an extra hour. I think that is something we should do. Even if this is called a private model, like private hospital, they have a bunch of bonus, right? It is very important in this situation. You cannot just, okay, you're a doctor, you're supposed to sacrifice. Your medical profession, nurses, people who work in the hospital, supposed to sacrifice. It's true, but also they have to live, right? So if they don't have enough money and they're overworked, they get stressed, they might eventually leave the hospital, and therefore you get less workforce, which is also bad for your hospital. So this way, I would think, having a higher up people try to think about this, that's very useful. And in fact, in my hospital, I know that I'm not like super in the position where I need a lot of money, but our students, our fellow who works a lot of hours, they deserve to have some benefit. So we put together all of our attendings say, hey, we're not going to get enough salary, a lot of salary. We're going to cut down on salary, just give this to fellow. Doesn't matter what. And the higher up in the hospital, the management level, the administrative level, they say, I'm going to throw away this portion of my money, use this to support the team. I think that's very, very generous. And that should be the way that we do stuff, I mean, if you get 1 million baht every month, but you're the admin part, right? There are a lot of people who are below you who really, really struggle, and they're the workforce of the hospital, but you're not, right? You're the top thinking brain. If you can cut some of your salary, put it to them just for that period of time, just have them get by, not so struggling. I think that would be very, very appreciative. And it should be something that we should all think about. Money is not something that is not important anymore. We have to think about. So I think those are the things I have seen that many, many people in the hospital have been trying to use in order to help each other out. Yeah.
Thank you so much for sharing. And it seems that you share very good practice in terms of management support, in terms of compensation, both in terms of financially and also psychological support. That's very interesting to know. And here would come to the last point of this talk. Could you share with us, from your opinion, the future of healthcare management after the pandemic?
Well, I think it's going to shift towards more of the telehealth. Those who really need hospital care, they will come to the hospital. Those who probably does not need the hospital care, they might use telehealth more. And telehealth means you have to have very good infrastructure in terms of internet access, the platform you use, and how would you connect with the other hospital. If they have different kind of electronic medical record, that would be quite difficult, right? So here in the United States, there are not a lot of electronic medical record system. So one hospital can see other hospital. If they grant access, then we are fine. I think that should be something that Thailand has to work towards. For instance, I know like different hospitals in Thailand, they have their own electronic medical record. And some of them are still using like handwritten paper or something like that. And if you upload that to the computer, it's hard to read sometimes and it's hard to understand, like all the doctor's handwriting, right? It's not easy to decipher unless you're in the medical profession. Even if you're in medical profession, it's hard to even understand what that means if it's not in your specialties. So developing the electronic medical records in the same system would be very, very helpful. And that would be in the country scale. But if you want to expand that to global scale, which is going to be important. For instance, if you're a Thai citizen, if you come over to the United States, can you transfer some of your record over to us? Maybe we can see them. That would be very awesome, right? So we can understand. What if you're in America and if you want to connect with your doctors in Thailand because certain problem? If you can connect with them via telehealth using Thai platform, that would be very good, right? How about if your doctor would like to order some medicine, but you're in the United States, you want to pick up something in the United States? There has to be a way to connect these telehealth to the pharmacy in the United States and do it from there. And then the insurance also has to be built in, something like that. I think that will be the future of the healthcare. You need to be more connected. And more connected comes with risk. What are risks? Well, a lot of your information should be confidence, right? Should be confidential. What if it's not? What if somebody is trying to hack your profile and then use it in the way that you do not want? What do we do? Have to deal with a ransomware, those kind of things. And there's a lot of instances in the United States where one of the big hospitals got a malware and then they had to pay several $1 million in order to get rid of it. So that's also something that people in cybersecurity is going to have more of a secure job. I would say people who are in cybersecurity, sometime, if you go through the normal path, might not work. We know for the fact that some people who work in cybersecurity used to be a real hacker before. They know inside out the back door. We need to use these people in a good way, not just like, okay, put them in jail. Well, they put them in jail when they come out, well, they're going to create another problem, right? And now they know how they get in jail in the first place. They're not going to repeat the same mistake. They might do something more discreet and then you're in trouble, right? What if you give them an opportunity to use them to work for the government, use them to work for cybersecurity and create a very good cybersecurity? Now they are challenged. Why? They're challenged because they have to work against other hackers, but they're now good hackers. So which is a good thing. And that's something to think about, in terms of cybersecurity has to come with all of these telehealth. So I think in general, connectivity is the future. People who are keen on doing the computer stuff are very, very in demand. Obviously, we are trying to build a system which is somewhat global, that we can connect everybody together, and everybody has to try to hook onto this. If you're not hooked onto this system, then you're left behind, and therefore you're probably not going to survive. Like all the insurance who does not want to switch their platform over to the telehealth or connectivities, they might not survive, and people might select different insurance instead. So that's what I'm thinking that might happen in the future and what we should be targeting towards.
Okay, thank you for sharing those. Definitely. I agree with you that in the near future, connecting would be big issue, and also the telehealth would be big issue for the future. Thank you very much for your time, Dr. Tany, and thank you for sharing your view with us. It is very helpful and useful for our students and our alumni. Thank you, and thank you everyone for watching.
You're welcome. Thank you.